This chapter is going to have a whole lot of new information for you guys, so definitely take good notes. All right, so we're going to talk about cardiopulmonary conditions and treatment. COPD that we talked about several times now was actually the third leading cause of death in the United States and costed annually, and this was back in 2015, so it's even more now, but it was estimated $161 billion in treatment. So it's a very expensive and very broad thing that we treat. It's probably between strokes and shoulder patients, COPD is right there with them as just as common. It's very, very, very common. Look at that sheet that I gave you guys. And as I go through, I'll probably refer to most of these as their abbreviations. So this is just a kind of to help you follow along. Look at your little abbreviation handout I gave you at the beginning of class. The ones that are highlighted are just my personal preference of things I see more often than others. I have seen all of these, but the more common ones I highlighted in yellow. It's not that they're any more important, they're just a little bit more common. AF is AFib or atrial fibrillation. A CABG or a CABG is coronary artery bypass grafting. We're going to talk a lot about what those are here in just a little while. CAD is a coronary artery disease. CHF is congestive heart failure. CM is cardiomyopathy or heart disease. COPD is, I spelled that wrong there, I'm sorry. It's chronic obstructive pulmonary disease. CPAP is continuous airway pressure. Is anybody familiar with this? A CPAP machine looks like? You guys have probably seen them. People sleep with them on their faces. It's constantly pushing pressure. Yep. HTN is hypertension or high blood pressure. METs are metabolic equivalents. We're going to talk a whole lot about that in just a little bit. And MI is a myocardial infarction or a heart attack. PLB is the pursed lip breathing. You guys remember what that is? I've talked about it several times now. Okay, and what does it look like? Do pursed lip breathing for me, Lindsay.
Right?
What?
Like, your lips together?
Yeah. Do pursed lip breathing for me. Okay, no one else is going to do it? Okay. In your nose and out your mouth. Everybody do some pursed lip breathing. What is the purpose of pursed lip breathing? Control your breath. Yeah. And you use your diaphragm muscles to push out all of the air. A lot of times COPD patients will tell you it's not that they can't get a good deep breath, it's that sometimes they can't get the air back out, which is just as common. And the last one that's super common is SOB or shortness of breath. Okay? All right, so let's talk real quick about the chambers of the heart. Go to page 669. So this should be a little bit of a review from anatomy, but there are 4 chambers. There's the right atrium, the right ventricle, the left atrium, and the left ventricle. The 2 upper chambers are the atria, and the 2 lower, larger chambers are the ventricles. The left ventricle, and you need to definitely write this down, the left ventricle is normally the most common area that heart attacks occur. Okay, and it is the largest compartment of the heart. So just reviewing a little bit of what circulation looks like, what it does. The venous system or your veins, that is returning deoxygenated blood to the right atrium in the heart. So it's taking blood that has been out toward your extremities, toward organs, and it's bringing it back to the heart. And then it's going to go from the right atrium to the right ventricle and pumped into the lungs. Once the blood is pumped into the lungs, it's oxygenated again, and then it is pumped back into the heart, and it is pumped into the left atrium, and then it gets pumped into the left ventricle and out to your body. Okay? It's going to be really important that you guys know that system and how it works. There will most definitely be questions about how blood circulates through the body on your exam. Okay. The heart also has 4 valves, and issues with those valves are common. The pulmonary, the tricuspid, the mitral, and the aortic valves. And they all open and close at a certain time. Your heart's a really neat thing. When you go through and you see, like on page 671, you know, an EKG reading, what that looks like, watching an EKG and watching the heart pump is actually pretty cool because you can see it if it's slowed down enough. You can see where each area of the heart is contracting, and when the valves are opening and shutting, it's really neat to see what all it entails. As far as us going into EKG readings and all that, that's not really in our scope, but it is important, you know, and interesting for you guys to know. So if they say, hey, here was my EKG reading, you work in, you know, acute care, it might affect how you do treatment with somebody. All right, so let's talk about heart attacks or myocardial infarctions. What are the first signs or later signs of a MI? Chest pain, that's the first one. Chest pain. Okay, what's another one? Pain in your arms. So actually, a lot of people don't know where all that pain can radiate from. You always hear from your heart into your left arm. That's what you always hear, right? But that pain can actually go up into your ear, into your teeth, into your jaw, anything like that. So a patient is complaining of chest pain. So are you having pain anywhere else? If they say in their jaw or teeth, don't dismiss that because that can definitely be a sign that a heart attack is getting ready to happen, okay? Or is actively happening. Nausea, vomiting, shortness of breath, excessive sweating, fatigue, all of those are symptoms of heart attack. Women actually are more common to experience heart attacks than men without having chest pain. So they may have some of the other symptoms, the shortness of breath, the excessive sweating, but women can have heart attacks more often so than men that don't have chest pain. Let me see. Where was I at? Oh, what part of the heart is involved with a heart attack? That's the most common. But what is the heart made up of? Which is called what? Very good. It's called myocardium. You're going to want to know that. Myocardium is heart tissue, the muscle tissue that makes up the heart. What are some preventable and non-preventable risk factors of heart attack? What are some preventable things? Diet, absolutely. Exercise, absolutely. What are some non-preventable things? Genetics, their age, gender, family history, all of that stuff plays a huge role in it. Tends to, if heart issues run in the family, that's why they ask you those questions when you go to the doctor. Is there any history of heart disease, diabetes, all these things that they run through? There's a reason there's a strong genetic link, especially with heart issues. Why is it important for the OTA to know what kind of medications a person is taking with cardiac issues? Why is it important? Why would we care about what type of medications they're taking? Some of them can make you dizzy, absolutely. What else? Thinning their blood. That one's really important because, a very small cut to your normal person that's not on blood thinners can be a huge issue if somebody is taking blood thinners, especially some of the more higher level ones. If you go to page 675 in your book, there are a list, there is a list of common medications for cardiac patients. Those are really important to know and what they do, okay? I know I've mentioned lots of medications throughout my semester so far, but these are probably the most important ones for you guys to know and know what they treat. Okay? All right, so let's talk about some of these treatments for myocardial infarction.
I have a question about the medication.
Sure.
Are you gonna want to know like beta blocker or if timolol is
No, I'm going to want to know the medication.
the name of
No,
specific?
no, not the specific, the type.
Okay.
Yeah, what a beta blocker does. One of the most common ones I do now that we're, we kind of stopped on is the diuretics. That's a huge one. That's used. You hear people say, "I'm taking my water pill." Has anyone ever heard that? That's what that is. It makes people pee and pee and pee and pee some more. A lot of people say, "Don't take it before bedtime because you'll be up all night peeing." There's really not a convenient time to take it though. If you talk to patients about it and their doctor doesn't really care when they take it as long as they take it daily. Most patients take it in the morning while they're home. So, because if they take their water pill, they will go pee and pee and pee. They'll pee and then 20 minutes later, oh, I got to go pee. And it's an emergency. Like they can't hold it. They really do have to go. What that is making your body get rid of that retained fluid that's causing the edema and the swelling. Any other questions on the medications, or are we good? So I want you to be familiar with the types that they are and the purpose for the medication, not so much the commonly prescribed types or the brand names as I am the purpose and the types. Okay, cool. All right, so some of the surgical interventions that they do for heart attacks is a balloon angioplasty. What this is they go through and put a balloon literally in an artery and blow it up so they can expand the artery. Because when someone has a heart attack, you're talking about the heart is not getting enough blood flow normally. And somewhere there's a blockage and the blood's not flowing as well. So what they do is they go in and they literally put a balloon through the vein or whichever artery and expand it. And then oftentimes they'll put in a stent right with it. So they're going to expand it with the balloon and put a stent in with it to keep it open. Apparently they can do balloon angioplasty is not put a stent. I don't know why you would, but apparently they do. I've never had a patient that had one and not the other. But the stent is there. It's a permanent fixture that will, keep the artery open. It's literally, I think of it as like PVC piping. It's literally like a tube that they put in to keep the heart from, or the artery open.
And once you get one, have one past it. Like they can't surgically put a stent past the first stent.
Unless they go in another way. Could always do that. Never ran across that. That's interesting. I didn't know that. And then an arthrectomy, that is, it's extremely similar to like a stent placement or balloon angioplasty, but they're removing plaque. Plaque is the reason that there's a blockage. Sometimes the arteries can get thin and stuff too. There's other reasons. So an arthrectomy is where they're removing the plaque. There's a precaution here that you guys need to gold star and know that once one of these procedures are performed, whatever extremity that they went in, because see, they're not going straight through in to a place that they're going through a vein or artery from the legs. A lot of times it's the groin. Sometimes they'll do it in the arms. It just depends on the doctor where they need to put it. It's all dependent on that kind of stuff. But they need to have, if they went through an extremity, you have to keep that extremity in extension for roughly like 8 hours. Okay, they can't be bending and whatnot because they had a major medical procedure. On the, more progressive end, they can do like 4 hours, but all of my patients have always been, they had to lay there for 8. Okay. I don't know.
Is that something that, will we ever be in an acute situation where we will see them in 8 hours?
What? Yeah, in acute care, maybe. And what you're going to do is mainly in that session, educate them not to move for 8 hours.
Yeah.
Typically, no, Isaiah, you're not going to. But in acute care, there's always a possibility. At the next OT session, when you can actually do stuff with them, normally they're able to resume normal activities as tolerated. And you need to be aware that if you have them do exercises, they're not allowed to have resistance. Okay? Very important to know that. No resistance. Okay? Any questions?
Body weight.
Body weight's fine. No additional resistance. Okay? Nothing really past gravity. All right, so some cardiac surgeries. If you go to page 673 in your book, there's a table there, 26.2. There's different approaches. You have the coronary artery bypass graft. That's the one I mentioned earlier. That's the cabbage. That's where a midline sternotomy, what does that mean? Play off words. What does that mean? They cut you. It's awful. It is such a long procedure and it's terrifying. Let's read on here. The heart is stopped and the client is placed on a cardiopulmonary bypass machine to sustain oxygenation. What it means is they literally have a machine doing the work for the heart and they stopped your heart so they can work on it. How terrifying, right? This is, the very little surgeries I think are more terrifying. And you can actually, if you want to, and I encourage you to do it if you're not super squeamish, you can go watch one of these surgeries on YouTube and it would blow your mind on how far medicine has come to be able to do something like that, to literally be able to stop a patient's heart, keep it working, doing the body's job through a machine, and then restarting the heart. How crazy, right? Yeah, it is common. Let me say it this way. It's becoming less common as they're getting better at it because it's always better to not stop the heart than it is to actually stop the heart. But around here, we're not the majority of my patients that have sternotomies, they stop the heart. Okay. All right, so you have an off-pump coronary artery bypass. This is where the surgery is performed on a beating heart following a midline sternotomy. This is the difference between the two. The heart is not stopped, so they don't need that bypass machine. Okay, this is going to be a much less not invasive because they're still literally cutting them down the middle and opening them up. They just don't have that. The difference is they don't stop the heart. Okay. And then an endoscopic one is the surgical incision is made between the ribs and the bypass machine is not used. They actually do the surgery kind of laparoscopically where they just do a small incision and can go in. That is becoming more and more common, but in bigger hospitals like the Rubies and the Cabell Huntingtons and CAMCs, they can do heart surgeries in most hospitals. And I know I would want to go to a bigger one where they did laparoscopically instead of having the sternum cut open because you'll see these people after they have a sternotomy, they normally, especially at CAMC, they get this heart-shaped pillow and they're always hugging it like this. It's to keep them from injuring themselves. That's a major, you talk about you're literally being cut down the middle and opened up like a book. Pretty invasive. Go to page, no, I already showed you that. There are some precautions with these. Clients should always avoid, after having this surgery, a sternotomy, asynchronous movements of the upper extremities. What that means is don't have them do an activity one-handed. For example, you don't want them to be reaching out because what are you doing? You're putting pressure on the sternum, right? You don't want them spreading their chest apart. That's the biggest thing. Okay, so one exercise you never have somebody do after they've had open heart surgery is never have them do horizontal abduction because that is exactly what you're doing. You're opening up their chest cavity. Avoid that at all costs because it has to heal. What I'm going over now, sorry, the title of it is sternal precautions. Okay. Very small. Don't open it up. It's not worth it. Okay. Next is clients should avoid any activities that cause feelings of sternal clicking or shifting as the sternum heals, meaning movement. You don't want to reach too high, too low, bend too much. Really, they're going to be like this the majority of the time because they're worried,
For how long?
That one is normally 4 to 6 weeks, but some people can go up to 12 weeks depending on how well they heal. and your surgeon. It really just depends on your surgeon. They'll tell you. You don't take them off sternal precautions. It's like weight bearing status. It gets changed by their surgeon. But you always hear these bypass grafts and stuff. People call them cabbage surgeries or cabbage patients. It's just easier than saying a coronary artery bypass graft. The next one is clients should not lift anything heavier than 5 to 10 pounds and should be very cautious with upper extremity weight bearing. Don't push and don't pull. Okay. This is where you teach the client that log roll method that we talked about in transferring. That would be extremely beneficial because you're not pushing, pulling with a log roll. You don't want them to pull themselves up in bed or anything like that. What is a major thing? Well, I don't know how to hint around to this with wheelchairs. If they're rolling their wheelchair, what are they doing the entire time? They're opening the chest, right? So to someone who is a fresh open heart surgery patient, are you going to teach them how to propel their wheelchair with their arms? No. How are you going to teach them to propel their wheelchair? With their feet. Absolutely. Good job, guys. And then I already kind of talked to you a little bit about the pillow, but they hold that really, really close. These patients, they're absolutely terrified they're going to open up their chest. I've never had a patient do that. I've heard horror stories of them not using that and not obeying the precautions. They have to go in and do some surgical repairs. But what it normally ends up happening if they don't is that the sternum doesn't heal correctly and they have pain for the rest of their lives unless they go in and surgically correct it. Okay. All right, let's talk about another condition. It is CHF. It is congestive heart failure. Just because the term says failure, it does not mean that the heart has failed. Not immediately. It means that it is slowly trying to die. It's slowly stopping to work. The heart eventually just when someone dies of CHF, it's just the heart eventually loses its ability to pump. All 4 chambers or any of the 4 chambers can be affected by heart failure. And these are the people that get the increased swelling and edema. This is because fluid is not being pumped throughout their body correctly, and it pulls most often in the lower extremities. You'll see CHF patients have very swollen legs and ankles and feet, even to the point where it will seep fluid because there's so much, it just has nowhere left to go, and it'll seep this clear fluid out of their legs. Even point like they'll be soaking wet with it. It's nasty stuff.
What's the fluid?
It names something. It's more or less water. It's just a bodily.
But it's not like sticky.
It can be. It's nasty. Don't touch it without gloves. No, not normally. Not with proper hygiene. It's just, it's clear. I don't even know how else I would describe it. It's clear, nasty liquid. I don't know. Like a lot of the times they'll wear shorts and it'll be pulling and their legs will be sitting in a wheelchair and I'll put a towel underneath their feet because it will, put water and stuff on the floor. It's more or less just water. It's just bodily fluid. It's not like urine or anything. It's just more or less water. I mean, it's been in their body though, so it's not super hygienic. Anyway, so some symptoms that are different from like a heart attack is that it's gradual. It's not sudden like a heart attack is. These patients are going to be on diuretics to try to get rid of that fluid. And often they'll be increased or switched if they start not working with patients. But CHF patients are almost always on diuretics. Okay. All right, so some other cardiac conditions, hypertension, we've talked a lot about that, but when someone says they have high blood pressure, what does that actually mean? What are we measuring blood pressure? What does that, kind of take that term for granted. What does that entail? Cassidy, what does high blood pressure mean? What gives somebody high blood pressure? No, that's not what I meant. Like what are we measuring? What is high blood pressure? Cardiac output, that's, yeah, kind of, yeah. Right. There's pumping of the heart. There's an increased force. So whenever you blow up the blood pressure cuff, what you're doing is literally cutting off that circulation, right? And that first beat that you hear when you're listening is where the circulation has then started, meaning that there was this much force pumping through. That's why I say if it's 180 as a high blood pressure, that means that there was 180 pounds of force, and that's what got through. If you don't hear it until like the 120 area, it was 120 pounds, which is normal, right? Does that make sense? Yeah. And then when you stop hearing it is where it returns back to normal flow, and that's your second reading. Does that make sense? That's what high blood pressure is. A lot of times, high blood pressure is it's just an exerted force. Most of the time, it can be through fluid. A lot of patients who have CHF, I have seen have high blood pressure with it because there's an increase in fluid. Cardiomyopathy. This is where the heart muscle becomes enlarged, thick, or rigid, and it can include a bunch of different conditions. The next one is angina pectoris. This is chest pain or tightness that results from a reduced blood flow in the coronary arteries. Angina pectoris. Okay. The other name for this is CAD, or coronary artery disease. OTAs, if you have a patient who, let me back up to these questions. I'm going to go to that in a second. What is the most common, or which one of these is most common to result in sudden death? Which one of these can result in most common, or will likely cause sudden death? After what I told you. These two. Very good. That's absolutely right. Which one of these often do you think has no symptoms? No of these three. You're good. Which one of these often has no symptoms? Do people have symptoms with high blood pressure? Yeah, so probably not that one. This came from reading. I know you guys hadn't read it yet, but we're ahead of the game. It's cardiomyopathy. It often has no symptoms. How scary is that? It's the one that is most likely to cause sudden death, but it also often has no symptoms. What I got to tell you a little bit about before you can answer the third question. Has anybody ever heard of a medicine called nitroglycerin? Huh? Nitroglycerin? Really? Okay. Well, no, it's not that much. What nitroglycerin does is it is a medication that is intended to stop a heart attack. So these patients, they have bad hearts. They're often prescribed nitroglycerin and said, if you have any chest pain, radiating, jaw, teeth, arm, that area, take a nitroglycerin. What that does is it's supposed to stop the chest pain. What it does is it opens up the blood flow. It's actually, my grandma takes them because she has a bad heart, but they're PRN medications normally. It's take this whenever you have heart and chest pain. My grandma took 2, which is not uncommon. You take 1. If the chest pain doesn't go away, you wait normally about 3 to 5 minutes. And if the chest pain doesn't go away, you take another one. It's administered. They put it under their tongue and it melts. If the chest pain doesn't go away, they take the second one. My grandma did that once, and I was with her, and she clunked out on me. She was sitting there talking to me, and all of a sudden, I thought she was having another stroke because I just didn't know what it was at the time. What it was is her blood pressure bottomed out because all of her arteries and everything was expanding. There was no pressure and it dropped. So her body went into a fight or flight kind of thing. And as soon as I laid her back, got her blood pressure regulated again, and her body she was fine. After that, it scared the crap out of me. But anyway, if you guys are working with a patient and they complain of chest pain, ask them, do you have nitroglycerins? If so, you can assist them in giving it. This is a medical emergency. You can help them take their nitroglycerins. You can go get them, say, here, put it under your tongue. Okay, it's a medical emergency. You're allowed to do that. If it doesn't go away, have them take another one after that 3 to 5 minutes and call 911 because a heart attack is probably getting ready to happen. Okay? Got me? That's protocol for nitroglycerins. But
No, that is the active ingredient in dynamite. So I was just very.
I don't know dynamite, so thank you. All right, so some impact of other cardio, or the impact of cardiovascular conditions. Edema is swelling, depression, fatigue, fear. Think about that for a second. If you had a bad heart and all that goes into that, the constant fear of having a cardiac episode and not being able to feel like you can go anywhere, or you may be a burden, or be in the wrong place at the wrong time and not be able to get help. It's very limiting to patients. There are some phases that we go through with cardiac rehab, and these are important to know. You go through the first phase, which is like the acute kind of thing, and you guys do have a knowledge assessment on this chapter, and it is about these. Okay, the first phase is like the acute care kind of thing. This is where we're going to be working on ADL retraining. We're going to be doing a lot of education about risk factors, ways to modify or decrease future risks of cardiac episodes. Some other things you might do, some home programs like energy conservation and task modifications, sternal precautions, all that stuff is in phase 1. You want to address each ADL in this phase because they're going to be doing them. Now, remember what I told you, that they can normally, after like say a stent or whatever is placed, as long as they follow that first like 48-hour precaution, they're pretty much back to normal, just with lifting precautions is normally the way it is. Now, sternal precautions are different if they had to have open heart surgery, but teaching them their precautions is all in phase 1. Okay? Also doing ADLs with them is phase 1. Phase 2 is like the outpatient side of it. This is normally about 6 to 12 weeks, roughly. This is where they're going to probably be doing a little bit of exercise that is supervised. That's a major component of outpatient therapy. And then phase 3 is like community-based rehab. Okay. Now would probably be the best time to teach you guys about what MET levels are. So after you're ready, you wrote down that stuff, or need me to repeat any of those phases? Are we good? Okay. Go to page 680 and 681. Has anybody heard of OT Mary? She's got a YouTube channel. Yeah, you guys are going to learn a lot about OT Mary because everybody uses her to prepare for their board exams. She's really, really good. Sometimes she can be a little bit difficult to listen to, but she breaks things down really, really easy. So I highly recommend her. I've got a video posted about these MET levels I'm going to teach you about, where she breaks it down really, really well. Okay. The first level is minimal. Okay, what this is doing is it's metabolic equivalent level, saying this is how much expenditure is going to be needed to complete these tasks, and going from lower end tasks all the way to high vigorous type tasks. Okay. Under minimal, the first one for like self-care, to give you an example, is having their hair or nails done by another person while they're seated. Something very minimalistic. Okay. Then we're going to take it up a notch to light. This is like bathing seated, eating seated, showering or toweling off and standing, those kind of things. Now, each one of these have a level beside of it. See how it says like 1.3, 1.5 and all that? You'll know like you can go up to this as a MET level. Okay. Next, we go up to moderate. Moderate, it's like some home activities like cleaning or sweeping carpet or floors, making the bed, stuff like that. Okay. And then we work all the way up to vigorous activity. This is like yard work, scrubbing the bathroom floors, stuff, the higher level type activities. Okay. I highly suggest that you guys watch that video. I posted it on eLearn. She breaks it down really, really well. It's about a 20-minute video. Take some time and take some good notes on that video. Okay. Cool. All right. Let's keep moving through. COPD. We've talked about this several times, so I'm not going to, completely rehash it. But there are a few terms I wanted you guys to be familiar with for being in a clinic. COPD patients are often called blue boaters. You may hear them called that. This is because they often will appear with a bluish tint skin because they're not getting oxygenated blood to extremities into the skin. So oftentimes they will look like they are bluish tinted. Emphysema. That's one we haven't really talked about a whole lot yet. This is where the air sacs are damaged and can rupture in the lungs. And then you'll often see patients that are called, that have emphysema, they're called pink puffers because they're often trying really hard to catch their breath and they're getting worked up and their face will appear pink and like they're short of breath because they're working really, really hard to try to get their breath. They breathe really quick. Antibiotics are really, really common for patients with COPD because they often will get lung infections. Most of the time they have to be given, and sometimes they can give them to them, orally. A lot of times they have to do IV antibiotics with patients with COPD, especially if they're later stages in COPD. It just because it works way better when you get something intravenously. Some other pulmonary positions that we haven't really talked about is cystic fibrosis. This is where they get a very thick buildup of mucus that blocks the airways for breathing. It's this nasty gunk that is blocking their airway. This promotes a really good environment for bacteria to grow, and they often will get lung infections that way. And a lot of people with cystic fibrosis are in and out of the hospital a lot. Very frequent hospital stays. Okay. Idiopathic pulmonary fibrosis, or IPF. This is a progressive lung condition. They don't really know what the cause of it is, but the lungs get very fibrous over time. They get scarred and they get stiff. They're not, simple in and out breathing. It makes it a lot more labored breathing. Kind of answered the question for you already, but frequent infections, they even have dietary issues. They tell them to limit dairy products because it increases the production of mucus. Cystic fibrosis is pretty nasty. You normally don't keep them on caseload very long without a hospital stay, unfortunately. Yeah, it's yeah, more or less. They end up getting it where it's so bad and so frequent hospital stays. A lot of times it's of lung infections that they can't fight off. Most people that have cystic fibrosis, and I don't know statistically if it's right, but most of mine have been in the younger years, not like, our age, but like 40s, 50-ish, because they don't make it super long, It's really sad because they feel like they're getting, something worked out. Sometimes they can go a while, but the majority of the time it's very frequent they get in the hospital. And they get resistant to the antibiotics, and they got to find new antibiotics, and it's a whirlwind. All right, so pulmonary rehab. During the, okay, let me back up. Not everybody's going to go through every stage I'm getting ready to mention. In an ideal world, yes, but with insurance and some patients don't want to go through each stage. It's totally understandable. During the first or acute phase, intervention is mainly focused on increasing independence with ADLs. It's extremely similar to the cardio rehab that we talked about. Second one is the outpatient rehab. This is where we're going to start giving the exercise type stuff to the patients. And then, they can always go into the community-based stuff too if they need to. And it's almost identical to the cardio rehab that we talked about. On page 688, I'm back at 686, sorry. I wanted to the box 26.1 down there that talks about the safe tips for oxygen handling. I think a lot of these go without saying, but you would be surprised how often these are not followed in homes where oxygen tanks are used. Avoid open flames. I cannot tell you how many patients I've gone in and they have oxygen running through their cannula in their nose and they're smoking a cigarette. That's dangerous. They have to immediately stop. If they don't or they refuse, you leave. You cannot have a patient on oxygen smoking. They can blow you up too. Don't do it. I had several patients I would argue till I'm blue in the face, like, listen, you have to put that out now. Like, this isn't, if they refuse, you walk out the door, go somewhere else. Okay. And then you call their doctor and be like, listen, so-and-so smoking with their oxygen. Let them know. Call your OT. Maintain a 5-foot distance between oxygen and any kind of heat source, whether it be electric or gas heaters. That one's a little bit harder to follow. People just don't think about it. They have an electric heater sitting beside their chair because they get cold easy. They pull their oxygen tank over there beside their heater. They don't even think about that, but it is a huge safety risk. Store cylinders safely. They should always be upright, secure, and in some type of an approved cart or device for storage. In home health, it's more common to see them laying around, but there's a lot of protocols for oxygen in facilities. This is actually something that I bet you guys did not know, that when using oxygen, you should avoid lotions or creams that contain petroleum. What is a really common one that has petroleum in it? Vaseline. A lot of people, they get dry noses and stuff, especially in the wintertime, but oxygen dries your nose out. A lot of older folks, the first thing they run to is Vaseline to put it on their dry skin. It's very dangerous. It is a huge safety. It's flammable. You don't want to put anything flammable with oxygen. Okay? So definitely keep that in mind. What you can tell them to do is use a water-based product instead. And if I'm not mistaken, I think Vaseline offers a water-based option now because it was such an issue. I don't know, maybe. No. Play off words, right? See if it has petroleum in it too, and then you can see if it's safe. And then another thing you're going to teach them about is their oxygen tubing and how much of a fall hazard it is. It makes me so nervous when you walk through and this patient is hooked up to their oxygen concentrator and they have this 50-foot cord, which is not uncommon at all because you don't want to restrict them to their chair. If they just need oxygen and they're still able to function properly, they will be all wound through their house, through their dining room. Kind of, I don't want to compare patients to dogs, but like when a dog goes outside on a chain and gets wrapped around chairs and trees and all that stuff, so common with patients too. You'll go in and it'll be wrapped around all kinds of dining room chairs, around their dog cage, around their chair, and they'll be sitting there and it's just barely have enough length left to put it on their face. I've had to untangle lots of patients, so keep that in mind too. It's a huge fall hazard. Do what? Yeah. It was back in the bedroom, but she'd run it all the way. She could sit out there. Yeah, a lot of people do that. You can even get extensions for it if it's not long enough, and you can go out into your yard and do it. I've seen it all. It's really something. I'm not going to rehash them because they're not super common, but on table 26.5 on page 688, that's common pulmonary function test. Those will tell you need to be familiar with those. because they tell you what the test measures. Okay, some of them measure air in, some of them measure air out. Okay. Right. All right, so a referral to other disciplines. When is OT not enough? Is basically what we're talking about. Although OT plays a huge role in treatment of people with cardiopulmonary conditions, often and most always other disciplines need to be involved. They may need physical therapy. They may need speech language pathology. They may need a dietitian. They may need a counselor, a social worker, a psychologist, respiratory care, all of these things. In order for you to be able to get a referral, how does that happen? Say if you are working with a patient and you say, I really think you could probably benefit from speech therapy. How does that happen? What's the chain of command? Right, but who's your first line of defense? Who do you go to first? Your OT. Go to your OT first. I just did that last week. I had a patient that said, I really think you could benefit from speech therapy. Let me talk to my OT about it. So I messaged my OT and say, hey, so-and-so could really use a speech therapy referral. How do you think, we could get that happen? Well, his immediate response is always, I'll talk to the primary care physician. Whoever ordered therapy in the first place is normally who they go to. And that referral gets sent to your place of business, and then it gets given to the right practice. So you can't automatically give a referral, but if you have a really good relationship with your OT, I've never had an OT tell me no. What do they have to lose from it? More or less is the way I look at it. I've never had an OT say, no, I'm not going to do that referral. We can do that. I'm all about more players, because if you get two sets of eyes on a patient, it's better than one. They may see something or come up with a treatment that's totally different. Even between OTAs, I've worked with an OTA now in home health for a long time. We graduated together, and I've been treating this patient literally for 2 years and on and off with her. And I go in, and the majority of the things that they had her working on was exercise-based stuff. Well, I totally went a different route with her because I saw the mental health issues as way more important. So I totally switched how I was going to work with her and what the treatment I was going to do. It's really important to get more than one set of eyes on people. And it's okay to go across disciplines. It's totally fine to say they might need speech, they might need PT or a dietitian or whichever. It's totally cool. I've done it many, many times. All right, so I need you guys to be really familiar from this point forward with those vital sign handouts that I gave you last semester. Okay, at this point, you guys should know how to take pulse, how to count respirations, how to take blood pressures, temperatures, all of that. You guys should be very familiar with that by now, right? Cool. If you don't, and you don't feel comfortable with it, come talk to me. We'll practice it. If you want to take something home, a blood pressure cuff or whichever, and you want to practice it, feel free. Just let us know before you take it. But you guys really got to be familiar with vital signs. Not only how to set or what they are, but you also need to know how to read them. Page 695 is a good refresher for cardiopulmonary ones. It's table 26.6. The blood pressure, the normal ranges and abnormal ranges. For blood pressure, O2 stat, respiratory rates, and pulse. Okay? You need to really be familiar with those ranges, definitely for practicals and exams. Cool? And practice. All right, so some people with cardiopulmonary disorders must learn to self-monitor. So this is where you take and educate the patient on these symptoms, okay? The first one is overexertion. What was one of the big things I told you guys about overexertion? What was like the golden nugget rule with overexertion? If they're feeling pain 1 to 2 hours afterward, you probably overdid it, right? Another way with overexertion is if they get really short of breath or have any kind of chest pain, you've overdone it. You've done too much with these patients, okay? You need to tone it down, or they need to tone it down. I've had patients that have come out of open heart surgeries, and within a week they're trying to install, or carry furniture and crap. I'm like, you can't do that. You've overdone it. No wonder your chest hurts. You tried to lift the couch. No, you can't do that. What's a sign of infection? Discoloration. Maggie, what's another sign? Hot to the touch. What's another one? Lindsay. Discharge, pus, that kind of stuff. Very good. You need to teach. Patients don't always know that. I've had patients where I can clearly see that their wound is infected, and I'm like, that's infected. Oh, I thought it was just healing. It's all part of healing. No, that's not. That's very, very bad. Normal wounds should not be having pus flowing out of them. It's not right. What about an impending cardiac event? What are the signs and symptoms? Chest pain, radiating where? That was great diagram. Teeth, arm. Most common is arm, but like I said, don't even up to their ear. Don't throw that out. That's definitely a sign. You need to teach them about that. And if they're having that chest pain, what do they do? And what? Perfect. Take nitroglycerin, call 911. Now, if they don't have nitroglycerin, skip that step, call 911, right? Most cardiac patients have, if it's not their first event, most of them are prescribed that as an emergency defense. A lot of lives are saved with nitros. Exercise intolerance. What's the side of that? It's extremely similar to overexertion. Fatigue. What did you say, guys? Labored breathing, all these things. And then edema. What's the sign of edema? Swelling. Look at your foot. Is it normal size? Is it swollen? That kind of thing. Absolutely. If they have increased edema, you might ask them what question? What was the common medication? Diuretics. I said, did you take your water pill today? No, I forgot. Okay, well, you might want to take your medication then, because you're leaking. Okay? All right. So you have 2 knowledge assessment questions for this chapter. This first one is match the phases of cardiac rehab to their location, their duration, and the areas that are focused on. Each answer goes with 1. So you might say phase 1 is this location, multiple duration, or 1 duration, and then multiple focuses. Okay? These are pretty much straight from the book and lecture. Okay? All right, your second one is, what do each of the following tools measure or monitor? Okay. That last one on there, you're going to have to read in your book. I did not go over that one. Okay. And then what are the normal rates or ranges for the following vital signs? Cool? All right. Go to. Does anybody have any questions? That was a lot of